Welcome, everyone. Welcome, everyone, to the latest on long COVID research with Dr. David Putrino, hosted by Body Politic. Thank you so much for joining us. My name is Lisa McCorkell, and I am the co-founder of the Patient-Led Research Collaborative, which is a group of people with long COVID conducting research on long COVID that stemmed out of the Body Politic COVID-19 support group. Through a global network of COVID patients, chronic illness allies, and health and disability advocates, Body Politic continues to break down barriers to patient-driven whole person care and well-being, particularly for historically marginalized communities, by facilitating peer support, cultivating patient-led research and public education, and leading community-based advocacy. It is my honor to introduce and welcome Dr. David Putrino. Dr. Putrino is a physical therapist with a PhD in neuroscience. He is currently the Director of Rehabilitation Innovation for the Mount Sinai Health System and an Associate Professor of Rehabilitation and Human Performance at the Icahn School of Medicine at Mount Sinai. He develops innovative rehabilitation solutions for adults and children in need of better healthcare accessibility. And in 2019, he was named Global Australian of the Year for his contributions to healthcare. Since the beginning of the COVID pandemic in 2020, David has been recognized globally as a leading expert in the assessment, treatment, and underlying physiology of long COVID. His team has managed the care of almost 2,000 people with long COVID and published multiple peer-reviewed scientific papers on the topic. He is an incredible ally to our community, and we are so grateful to have him today. Dr. Putrino?
Thank you so much. It's an honor to be here. Working with Body Politic and just having conversations with Body Politic since the very beginning of this journey has really been so eye-opening for me. So I'm going to go ahead and share some slides. I think I'm going to turn off subtitles because I see that this is being transcribed. Today I just wanted to cover as much material as humanly possible, share everything that I know up until this point. I know that this is a really engaged community, and I know that a lot of individuals have gone out there and viewed a lot of content and read a lot of things. So I apologize if some of my slides and some of the things that you're about to see, you've already seen me present on or talk about, but I figured we would just tell as complete a story as possible and then have some time for questions as well. The first thing I wanted to really push on to begin is I feel like we're in a really odd time in the whole long COVID journey. And so I really wanted to make a statement about the fact that I have nothing to disclose. This is a statement that, you often say at the beginning of scientific sort of presentations and so on and so forth, but I wanted to dig into what that actually means and be just as transparent as possible with the group. I don't receive any money from companies to consult on long COVID topics. None of my staff, we have a long COVID clinic. Myself and my staff, we don't get paid extra. Our salaries don't increase by seeing more patients. There's no way for us to monetize seeing people with long COVID. I also want to point out that I sit on the scientific advisory board of two companies that work with people with long COVID. One is called Stasis, which is a breathwork company some of you may have been introduced to. Another is a new company called Visible, which is a patient-led company, which is health tracking for people with long COVID. I have agreed to sit on both of these boards and provide advice that I think might be helpful, but I don't receive funding for them from them in any way, shape, or form to provide that advice. And when it comes to speaking about long COVID, I don't accept speakers' fees or honoraria to speak. And more often than not, if possible, if there is a choice, I will ask a speaking fee to go to groups like Body Politic, so that they can continue doing the amazing work that they do. So I wanted to get all that out of the way because I know that there's a lot of, dueling voices and theories and so on and so forth. And I really want this to be open and transparent. I really want this conversation to be just about what we know and what we don't know. And so I wanted to make it clear that there is, anything I'm saying right now is not, I'm not funded to say it. It's just what I know, and I'm here to learn as much as anyone else. So, as Lisa, with a very kind introduction, as she mentioned, my background in clinical work is as a physical therapist. My scientific background is as a neuroscientist. And my title at Mount Sinai is the Director of Rehabilitation Innovation. What that means is that I get to do a lot of interesting work around integration of new technologies and new treatments into the practice of rehabilitation medicine and rehabilitation and human performance. I get to operate and run 3 different clinical research centers. One is called the Charles Lazarus Children's Ability Center, which focuses on providing novel interventions to kids. One is called Performance 360, where we get to work with high performance athletes and kind of understand how they tick and how they do what they do. And the final one is called the Abilities Research Center, where we do a lot of our research around novel technologies to help people with severe disability. I just wanted to give a quick overview. I'll give you, we run about 35 to 40 different projects at any one time, and we see a few hundred patients, every month. But I just wanted to give 3 snapshots of the sorts of projects that we work on, because I just wanted to give a sense of the range of things that we work on, because I think that's important for how we got pulled into the whole long COVID space. So this is a project that we love at the Charles Lazarus Center, and it's called Therapy as Play. This consists of us building all sorts of both physical, so real, and virtual rehabilitation experiences for kids that encourage play. So it encourages rehabilitation for kids, typically with neurological conditions, that really doesn't feel like rehab. It feels like they're having a good time and getting to play with their favorite toys or their favorite video games. A project that we have ongoing at the Abilities Research Center. This is a technology called Stentrode. It is a brain-computer interface that allows us to place a stent inside of a blood vessel. From the vantage point of the blood vessel, we can record brain activity, and patients with ALS, which is a motor neuron disease, can use this this implant to control a computer just using their thoughts. So we've already implanted 5 people in Australia, and we will be conducting first in human in the US in a few short months. So, this is the sort of novel technology that we try to get out there to improve the lives of those who are severely disabled. And then Performance 360, we're just wrapping up a study where we threw a bunch of big wave surfers. This is a Red Bull sponsored surfer on a 100-foot wave in Portugal. We threw a bunch of these guys and ladies into a functional MRI scanner to try and understand what is going on in their head when they decide that they're going to jump on a wave the size of a building. And this gives us insights into how the brains of elite performers are different to everybody else's. So the reason I'm telling you all of this stuff as background is because this is my job. This was my job before COVID. It was to work with diverse populations. It was to never be siloed. It was always to think about what is an unconventional way that we can get to the goal that we need. And so when COVID hit New York City, our team did a lot of work in both the initial phases when we were dealing with a lot of acute COVID, all the way to now when we're dealing with long COVID. And so I wanted to start there. Long COVID first landed on our radar in around April of 2020. My team had become aware of this problem that that Mount Sinai and many of the health systems are having in New York, which was, as we were building all of these triage tents in sitting in Central Park for acute patients who were coming in for care, we didn't know much about the virus. So this is a photo that was taken on March 14th of 2020. And at this time, no one knew anything about the virus. And what we did know was that we were running out of beds in the hospital. And so if you showed up to a triage emergency tent, more often than not, if you seemed like you could walk your way into the tent and you could hold your oxygen levels at a healthy level, you were told, look, we don't have a bed for you right now. If you get sicker, come back, but otherwise go home. So with that in mind, what we did was we created a remote patient monitoring app. My team has a lot of expertise in developing these platforms, and so we rapidly built one that was focused entirely on respiratory health. So identifying who was going to rapidly go into respiratory failure was the goal of the app, and we deployed it as quickly as we could. So our first patient onboarded by March 15th, and we had over 100 patients being actively monitored on a daily basis within the week, and then it only grew from there. So we had several thousand people being monitored on a daily basis, and it was pretty simple. You checked in every day, answered a few questions about your symptoms, you tracked your blood oxygen levels. On a weekly basis, we would have a physical therapist, a physician, or an occupational therapist check in on you and make sure that everything was going okay. If anything was not looking so good, you would quickly get escalated to a doctor who would then make a decision as to whether a patient should be admitted or not. And that was how we did it. We ran this program for about 9 months. We treated thousands and thousands of New Yorkers and a few people outside of New York when they didn't have any other options. And as I mentioned, by around April, we started to see about 10%, 15% of the people that we were tracking in the app, they just weren't signing off the service after 3 or 4 weeks. So most people, 3 to 4 weeks, they'd say, okay, I'm not feeling perfect, but I'm feeling good enough. Thanks for watching over me, and see you later. But there was this sort of small percentage, 10, 15%, not a small percentage of, a reasonable proportion of individuals that were staying behind, and they were now presenting with new symptoms. This is actually a word cloud of in the app. We had an other button that you could hit about your symptoms, and you could say, I'm experiencing other symptoms. Can you write in the other symptoms? And when we took the other symptoms that were being written in and we turned it into a word cloud, this is before long COVID was a named condition. This is before we had support groups. This is just from 100 or so individuals who were lingering on our app and describing new symptoms. This is what came out. So as you can see, fatigue was big, palpitations was big, heart beating, memory, exercise, because they were saying that they couldn't exercise the way they wanted to. All of these symptoms that should seem very awfully familiar to all of us now were so consistently being reported by the community that was just listing their symptoms in our app. And this was when our team really sort of zeroed in on this and thought, okay, well, this seems like some sort of post-viral symptom. Surely something's going on here. We need to start to think about how we're going to be treating these individuals, because that was the question that was coming through. We had individuals that would very faithfully adding in their symptoms, and then they would say, hey, by the way, like, what are you doing for us? Because I'm not getting better. So we wanted to take a very systematic approach to what we were doing, but we also had to move fast. First thing is just to understand what we're treating. And I think that long COVID, as defined by the CDC, the NIH, there is a pretty decent umbrella description of long COVID now, which is any new, returning, or ongoing health problem experienced by people 4 or more weeks after an initial coronavirus infection. So really pointing out the idea that your long COVID symptoms could be new. So you didn't have them before, now they're here. They could be returning. So you may have had a health condition in the past. The health condition is gone. You've been healthy for many years. Then you get COVID and suddenly the health condition has returned. Or you could have an existing health condition, and because of COVID, it got much worse than we would expect in the time frame that that the worsening has occurred versus what you would expect from a natural progression of the disease. So, you know, long COVID or post-acute sequelae of COVID can be any of these things according to the CDC. I tend to like this as a definition because it is as inclusive as possible. And I think while we're still trying to define what it is that people are experiencing, the more inclusive we can be, the more likely it will be that less people fall through the cracks. And, you know, I also think that a statement that should be made is, even though this sounds really, really obvious, long COVID is an infection-associated illness. It is, you know, an organic illness that has occurred as a result of an acute infection, just like ME/CFS, just like Lyme disease, just like many other forms of autoimmune conditions. This is an organic illness that occurred as a result of being infected with a virus. And so moving on from definitions, our first step was to catalog the symptoms. So we've published a lot on this, but this is a wonderful figure from the patient-led initiative. I think that, you know, elevating and centering patient-led voices as much as possible is super important. And I haven't seen a better paper out there than this one describing all of the ways that COVID can, that long COVID can affect organ systems and can present as symptoms. So, you know, although we were doing similar work, I think that this is a really wonderful description of the symptoms that are going on. And that was our first initial sort of idea, was as we start to think about treating, what are the symptoms? What are we seeing? The next is work on symptomatic relief. We knew and we know that understanding underlying pathology is a ways off. We've got a lot to learn. We've got a lot to understand. So we started to think about working on symptomatic relief. And we started to build a bit of a pipeline for clinical care. So we started with a full workup and cardiac clearance. The reason that we did this is to make sure that anyone who was in immediate, severe danger of loss of life, high risk illness, was cleared. So, you know, I think that over and over again, the thing that has rattled around in my brain as we've seen a couple thousand individuals with long COVID is, if this was anyone off the street and they present to you with chest pain, heart palpitations, feeling like they're about to pass out at any moment, you're worried about their lungs, you're worried about their heart, you're worried about their brain. So clear all of those things. Don't just assume that this is long COVID and it's not going to result in immediate death or something very, very severe. You need to clear it. And so that was our first step, always, is make sure that heart's clear, lungs clear, brain's clear, as quickly as possible and as efficiently as possible with the initial clearance, so that we can start to deal with some of these symptomatic issues. So now the next step that we really focused on was to begin work on behavioral strategies to get symptom attacks under control. As we are working on cataloging all of the symptoms, our personal thought process was that we were dealing with something that looked to us like dysautonomia, which is a dysfunction of the autonomic nervous system. The autonomic nervous system being the part of your nervous system that is basically on autopilot, doing all of the things that your body doesn't usually want to have to think about. When to sweat, when to digest food, how to regulate blood pressure when you're going from sitting to standing or laying to sitting, so that the same amount of blood is perfusing in your brain and you don't feel lightheaded and pass out or feel like you're going to pass out. All of these things that our body kind of very cleverly and intuitively does by itself, we can't take these for granted anymore when dysautonomia occurs. So we were cataloging not only common symptoms of long COVID, but also common triggers. As many of you can see here, these are probably very familiar triggers to those of you who are listening who have long COVID. As you can see right up the top, physical or cognitive exertion is one of the most common triggers. So coming up with different ways of avoiding triggers or mitigating the triggers was a very important first step to just help people manage the symptoms they're experiencing. So working with having conversations about pacing and energy conservation so that people could avoid exertion, understanding that exertion can be lots of things. Exertion can be being on a Zoom, exertion can be walking down the stairs to get your groceries, exertion can be aerobic exercise, exertion can be having a difficult and emotional conversation with a family member. These are all forms of exertion that can cause post-exertional symptom exacerbation. So understanding these things and finding ways to work within energy envelopes and understand how to fit different things into your daily life, have difficult conversations when you have more energy, et cetera, became very important. Lots of environmental planning that ranges from making sure that your temperature is controlled throughout the day, if you can manage that, all the way through to, making sure that your home is set up in a way that is optimal for energy conservation, making sure that you are able to do different chores at optimal times and so on and so forth. So being very individualistic in the way that you do this with people with long COVID who are coming for care, but really just working through everything in their daily life to focus on optimizing the environment. Hydration plan with electrolytes. So lots of hydration, lots of salt, so long as your cardiologist is okay with that and you don't have any pre-existing conditions like kidney conditions or hypertension that would preclude you from loading up on salt. Planning meals and meal times. A lot of individuals we've been working with have struggled with severe symptom attacks after eating a big meal, or sort of go day to day without eating much at all because they know that they feel worse after eating. And so having a very sort of disordered eating pattern of binging and crashing to at least only experience a bad feeling after eating once in a day. So working on plans to plan meal sizes, times of meals, et cetera, et cetera. Strategies for blood pressure regulation, including wearing tights and other compressive garments that assist with blood pressure regulation, especially when you change positions, and just mindfulness around caffeine and alcohol consumption. Many people have mixed responses to both. So just working that out and understanding where the line is to make sure that you can use these substances if they help, to the point that they continue to help, and avoid them when they're not helping. So this is just, there's so much to cover, but this is just a small overview of some of the environmental and behavioral strategies that we would put out there. We also really strongly recommended working with MyMe. These guys have been working in the autoimmune space for a really long time. They do behavioral health coaching, and many people who have been referred to Miami have reported back positively to us that that it was really quite helpful for them. So, you know, they're definitely worth a look if you're looking for some behavioral health coaching to help with some of your symptoms. This is anecdotal, but what we have seen from our clinic is that, again, this is symptomatic care. So if you do all of those things perfectly and a ton more, which I need to, you know, really keep stressing, it's a privilege to be able to do all of those things. It is not easy to do all of those things right. And there's a lot of, you know, mistakes and finding the lines over time. But if you can do all of those things right, we typically see a sort of 20 to 30% improvement in the intensity of symptoms for individuals just by changing a lot of behaviors. So, you know, it can be powerful, but it's also a lot of effort. It's a lot of time. And I fully acknowledge that a lot of people, you know, can't fit a lot of this into their life. So this is, we'll get to that later in the conversation. So from working with behavioral strategies, we would then refer to breathwork for breathwork coaching for prehab. So something else that we published last year was that individuals with long COVID tend to have lower levels of carbon dioxide compared to people without long COVID, healthy individuals without long COVID. We don't fully understand the mechanism behind this right now, because what we also showed in this publication was it was not accompanied by a significant increase in respiratory rate. So it's not like you're breathing faster and blowing out all of that carbon dioxide, but for some reason, carbon dioxide levels are low. And that can lead to all sorts of metabolic conditions and symptoms that are systemic and quite disabling. So we were incredibly fortunate to be working with Josh Dunst, who's the founder of Stasis, which is a breathwork coaching platform. And we were working with Josh on athletic performance, working with athletes to teach them about breath holding and breathwork and benefits of breathwork. And Josh is a veteran, and he had worked with Air Force pilots who had similar symptoms. And he was like, you know, I've seen symptoms like this before, and it usually is hypocapnia, low CO2. So he and the Stasis coaches developed a breathwork protocol that was targeted toward increasing CO2 levels and getting people more comfortable with what we call CO2 retention. So there's a risk that even if you have chronically low CO2, if you start to inch up your CO2 levels, your body's going to say, hey, CO2 is a waste product, you don't want it coming up, and you start to get anxious and breathe faster to blow off the CO2. So his exercises focus both on gently increasing your CO2 levels through breathing techniques like box breathing and others, and then also breathing techniques that assist you in being comfortable with CO2 retention. So Stasis have been incredibly generous throughout the pandemic in making this material free to anyone with long COVID. And we have been reviewing their data, and we're actually preparing some of their data for a publication. But over 80% of people who have been on the program for at least a month say that they feel at least improved. So we have a Likert scale of, you know, that you're feeling much worse, about the same, better, and much better. And 80% of people who have been on the program for a month feel at least better. So it's exciting to see once again that this is effective in treating symptoms. So breathwork has been really handy. We also refer out to other specialties for some of the different symptoms that we're seeing: nutrition, cognitive rehab, neuropsychology. I want to say a few words on some of these specialties and you know what's new and what's interesting. and what's got us stumped. So this is Adina Neglia. Adina is one of the most amazing registered dietitians that I've had the pleasure of working with. She works with high performance athletes. She's the dietitian for the Brooklyn Nets, and in her spare time, she's kind enough to help me when I'm banging on her door saying, "Help! We need a good nutritionist." She's seen it all, so she's been working with many long COVID patients, and low histamine, low FODMAP, low allium, nightshade-free, gluten-free, dairy-free, every diet you can think of, she's worked through with people with long COVID. The bottom line that we've seen on dietary changes is it's highly individualized. So increased food sensitivities are very real. So people experiencing food sensitivities that they never had before, absolutely a thing, but they're not necessarily fitting a pattern across the board. So, we are seeing people who show all of the classic signs of MCAS, mast cell activation syndrome, and do really well on a low histamine diet. But then we see other people where a low histamine diet does nothing. So working with everyone on an individual level has been really important for Adina. And also, and many patients are presenting with gut dysbiosis. So working to, working through prebiotics and then probiotics and regaining a healthy gut has been really important for many long COVID patients that Adina has been seeing. And again, more on that a little bit later. Intuitive eating is the way to go. Making sure that with every bite that you take of a food, you're really sort of processing, what is this doing to me? How am I feeling? Getting a healthy relationship back with food, because I think it's really important to note that so many people that Adina has been seeing are actually malnourished because they're trying to follow a highly restrictive diet. They're not getting enough calories, they're not getting enough nutrients. And that's also not a situation you want to find yourself in, even if there are a lot of foods that you're suddenly sensitive to. So working through it with Adina has been really helpful for a lot of patients. And, if you don't have access to a nutritionist, at the very least, just eating mindfully and really focusing in on what different meals are doing to you, so that you can find your own rules, is important. Because I'm here to tell you at this point, I don't think that there is a cookie cutter, one size fits all perfect diet for people with long COVID. I'm very open-minded to this, but I just haven't seen one of these diets solve everything. Cognitive rehab, I wish I had better news for the group. We've seen some people have improvements in their brain fog and their reported cognitive symptoms with autonomic rehabilitation, but it is not a consistent gain. We've tried brain games and other technologies that have worked with other forms of cognitive dysfunction after traumatic brain injury and stroke, and they don't appear to work as well in long COVID, and often can be just needless exertion. So you're doing something stressful and hard in front of a screen, and it's wearing down your energy levels, but you're not improving cognitively. So we're kind of pulling back from some of those. And lifestyle strategies, such as those we teach to individuals with traumatic brain injury, can help with management of symptoms, but they're not improving the cognitive symptoms. So we are still very much actively researching, and again, I'll speak more to that a little bit later, but right now we're not seeing anything moving the needle significantly on the cognitive rehabilitations, the targeted cognitive rehabilitation sort of side of things. Please bear with us, and we're going to try and continue as rapidly as we can. Social support, we have just teamed up with a group called Moodify. This is actually a platform that was designed for individuals with MS who are coming to terms with suddenly being diagnosed with a chronic and debilitating neurological illness. And Moodify is a platform that allows you to just share daily experiences with a community. And, no matter what you're going through in health or life in general, social support is always powerful. And so we're just big allies and advocates of social support. So we're looking to see if Mutify is a platform that is enjoyable and helpful and supportive to individuals with long COVID. If you want to try it out, this is the email address, erica.brayman@mountsinai.org. And Erica, who is incredible, will set you up with the appropriate people to get you involved in the platform. Okay, so symptomatic relief. The final thing I want to talk about is autonomic rehabilitation. So real big props to Jenna Tosto Mancuso here, who is our resident autonomic rehab expert. She developed a specific autonomic rehabilitation protocol for individuals with long COVID. This is, I want to be really clear, because I feel like autonomic rehabilitation, whenever I talk about it, it is a sensitive topic and people get upset at me. This is not exercise therapy. We're not treating deconditioned people with long COVID are not deconditioned. They do not need exercise, graded exercise therapy. They do not need mild exercise to improve their deconditioning. That is not what this is, and that is not what we advocate. So autonomic rehabilitation is rehabilitation that is specifically designed to treat autonomic dysfunction. The way that we start the majority of cases is we place people in specific body postures and walk them through movements that will trigger a slight autonomic activity. So for instance, laying flat on your back and slowly sliding up one leg to a bent position will cause blood to flow from your leg into your body cavity, which will cause a slight increase in heart rate. And what we train is breathing through that increase in heart rate to slow your heart rate down. And what we do over time is slowly increase the rate of the movements. We slowly change the positions that the movements are occurring in so that they're more challenging. So from laying flat to semi-recumbent to sitting up to standing. There may be progression to exercise at some point, but we only progress to exercise if it is a goal to increase exercise tolerance, and if it is not causing post-exertional symptom exacerbation or post-exertional malaise. So although rehabilitating the autonomic nervous system can ease symptoms of long COVID, there is no point progressing someone to running on a treadmill if you're just going to cause a crash, even if you're continuing to rehabilitate their autonomic nervous system. Understanding that some autonomic dysfunction is going to stay with people until we can understand what the underlying cause of long COVID is, so that they don't have post-exertional symptom exacerbation, is a very important nuance that I think is often lost. And we keep trying to speak out about this, that we do not advocate for people to get on a treadmill and work as hard as they can and push through pain if it means that they're going to crash over the next few days. So, an advocacy point here is, if you go to a provider and they're offering you autonomic rehabilitation and you walk in the door and they start talking to you about things like the Levine protocol, which is getting someone on a treadmill and moving, doing aerobic exercise, walk out the door. That is not autonomic rehabilitation that is appropriate as a starting point for anyone with long COVID. You need to start at a much, much, much less exertional level that does not in any way look like aerobic exercise. This is, again, this is intense, this is time consuming, this is challenging. So, one of the things that we're concerned about is that this is not accessible to everyone, but, these are things that we're working on in terms of advocacy. Jenna, in her ample spare time, has trained hundreds of physical therapists on this technique around the country and in fact, around the world. We have in early pilot data from 113 individuals who have been through a program, and we can see improvements in function, and we can see easing in symptoms. One of the most significant symptom easing examples we see is in fatigue. So people's fatigue is much improved. This is a little bit confusing, but the fatigue severity score, which is one of the more validated fatigue metrics, higher is better, which is kind of stupid, but that's just the way it is. So what you can see is individuals who are followed up after about 3 months of rehab are experiencing much less fatigue than when they came in the door. But the other thing I want to really point out is that after 3 months of rehab, people are still reporting symptoms. So once again, I need to stress that nothing I am offering here in this section is a cure. This is how to ease symptoms. And I want to be clear about the framing. These are strategies for easing symptoms, and they should only be used so long as they are easing symptoms. They're not treatments, and so you should not persist with them if they're not easing symptoms. Bar graphs hide a lot of things, and within the things that are hidden is the fact that some people don't get better, some people feel worse, and what we try to do is follow up with them and stop the treatment and say, listen, this isn't working for you, we're going to try and come up with something else. So I just really wanted to try and make that clear, because we have seen positive responses to autonomic rehabilitation, but we've also seen negative ones. It is not the be all and end all of treatment, but in the majority of people we've seen so far through our clinic, it does ease symptoms. And if you're in New York and you're interested in accessing autonomic rehabilitation, we have a trusted network where Jenna has trained literally, over 100 physical therapists in this network, and you can get on this page by just Googling Trusted Network Mount Sinai, and you can find COVID trained. If it says COVID trained, that means Jenna has trained them on how to deliver this autonomic rehabilitation. And if something doesn't feel right, ask us questions. If you feel like you showed up to a clinic and they didn't do it right, send us an email on this email address and tell us, hey, you should take them off the list because something isn't right here. Please let us know. We can't fix it if we don't know, and we want to hear from everyone. Also, resources that we love, long COVID physio for additional symptom relief and symptom management. Long COVID physio have published a ton of really great content, and they're really worth looking into. And the American Association for Physical Medicine and Rehabilitation has been working collaboratively with Body Politic. Body Politic very kindly offering many of their members as patient advocates to create consensus guidelines for physicians. So keep an eye out for some of the literature that's emerging from that body of that group as well. So I've talked about what does long COVID look like? How do we treat some of the symptoms for symptomatic relief? Now we got to talk about exploring pathogenesis of long COVID. So there are about 3 prominent theories that are really popping up right now for what could be the underlying cause of long COVID. I really want to point out it could be all 3 of these. It could be one or the other, and it could be different in different people and different presentations of long COVID. It's really too early to tell. But there is one theory of viral persistence. So the virus is still in the body. There are emerging papers showing that parts of the virus, so spike proteins or whole virus, living virus, is being found in the body in different tissues. And so there is a reasonable theory that some of that existing virus that is floating around is continuing to cause symptoms and cause trouble. The next is chronic inflammation. So, you had an initial strong inflammatory response to the virus. We've all heard of cytokine storm. Cytokines are inflammatory molecules. So the virus hit, you released all of this inflammation, And now sort of, it's led to this self-sustaining inflammatory process. The best example I have of this is like, if you've ever really terribly sprained an ankle and your ankle blew right out, and then in some cases for months or years afterwards, you have this low-grade swelling around your ankle because the inflammation is still just there simmering away for a really long time. That can also happen systemically. And that's one theory of what is causing all of these symptoms. And finally, autoimmunity. So this is when the initial immune response that the virus triggered, because it was a novel virus, our bodies had never seen it before, was so powerful that the body starts to produce molecules that go on to attack themselves. Your body starts to mount an immune reaction against its own tissues. So we are running down the pike, looking at all of these possibilities to try and understand what's going on. I'm really proud to say that we've had a wonderful collaboration with Akiko Iwasaki out at Yale to chase down the autoimmunity story and really try and understand what is happening with the chronic inflammation, the chronic cytokines and autoantibodies. With Akiko, we've taken blood samples from over 100 individuals with long COVID and many individuals with who are healthy controls or recovered from COVID. We're seeing findings that are consistent with autoimmunity in many patients. So we're seeing biomarkers of overactive B-cell immunity and significant autoantibody production. So it tells us that the body is mounting an immune response against itself. But I think one of the things to point out here is that many of the biomarkers we're seeing are person-specific and symptom-specific. So this is actually a figure from a paper that Akiko and I were co-authors on, showing that in individuals who report having brain fog, there's a certain cytokine that presents more readily than individuals who don't report having brain fog. And I think that this is what we may see in the autoantibodies and the cytokines is, depending on your symptoms, you will have a different constellation of autoantibodies and cytokine presentations. And we need to start teasing that apart in a very personalized medicine kind of way. But this is also very frustrating because it's not leading us to a hard and fast biomarker just yet. So we need to keep looking in this direction. But right now we're seeing very personalized responses. And I think it's also worth mentioning, because I always read some of these papers and think, so what? So what is right? We also, the next step in discovering these things is coming up with targeted molecules to treat overactivity of certain cytokines, because we don't yet have targeted treatments to address these findings. Viral persistence. Our team is working closely with Saurabh Mahandru and Amy Prohl, both pictured here. Saurabh published a phenomenal paper late 2020, I believe, showing that individuals with persistent GI symptoms post-COVID, he could find a lot of virus in their GI tract. The viral persistence story, I like it because it's probably the most simple explanation for all of these symptoms. Virus is hiding out in tissues, causing trouble, and that's what's causing the persistent symptoms. So the next step in understanding how viral persistence is working is, and this is the work that we're doing with Amy and Saurabh, is actually running deeper analysis. So once you find the virus, actually running deeper analysis on the tissue to see genetically what the virus is doing to the tissue. Is it just free-floating virus, which, by the way, happens? So you can get infected with a virus, the virus goes away, you get over it, and virus can still be in your system, but you don't have any symptoms. That can happen. What we want to know here is that virus that is floating around and being found in all of these different tissues, is it actually interacting with the tissues, causing immune reactions, causing toxicity, and driving the symptoms? That's the next step in understanding whether some of these virus fragments or living virus are actually causing problems. finally, I would be remiss if I did not talk about clots and microclots, and what has become affectionately known as hashtag Team Clots on Twitter is a wonderful collaboration of patients, physicians, and researchers from all around the world who've come together to chase this theory. A big shout out to Ricia Pretorius and Douglas Kell, who were amongst the first to really be thinking about this. And what they've been showing is that individuals with long COVID show signs of platelet pathology and microclot formation in their blood. And these microclots, and this is a figure taken from Ricia's work in 2021, showing this PPP is platelet poor plasma. They take blood out of your arm, they spin it until they get the platelets out, and they look at the plasma. And in healthy controls or people with diabetes, they chose diabetes because they wanted to see, if individuals with other cause endothelial issues and vascular issues had microclots. Turns out they do not. And then individuals with acute COVID-19 were starting to show all of these microclots in their blood. And what we started to see over time is that individuals with long COVID also had microclots. So this is new pilot work, thanks to Beata Jäger in Germany, and a bunch of amazing patients and clinicians and scientists. A team of individuals went out to Germany and ran 19 patients through a process called HELP apheresis, which is sort of pictured in a diagram up here on the upper right, where you it's basically a blood filtration system that is taking out some of these autoantibodies and these inflammatory cells and these microclots. And I'm really hopeful that tomorrow we'll get this paper out on preprint, so keep an eye out. But the good news is that in these 19 patients, we saw one thing that was very encouraging, which is the amount of microclots they had in their blood correlated with symptom severity measures that we were tracking on the clinical side. That's the first time I've seen that, and so I was very encouraged by that. The second is that a single session of HELP apheresis, as you can see here, both cleared microclots and had a significant impact on their long COVID, the patient's long COVID symptoms, particularly their gait speed, their speed improved, and their cognition, which we measured with a battery of cognitive tests. The less good, the things that we really need to work on, because this is a new technique. Well, it's not a new technique, but it's a new technique for long COVID. This was not a controlled trial, so this was 19 people. It's not a lot. We need more. The less good is that we saw evidence of microclots returning after apheresis, meaning that we still need to nail down what the underlying cause of this microclot formation is. And I also want to really just take the time to point out that apheresis is pretty extreme. You're putting a 16 gauge needle in your arm, blood's coming out of your body, it's going through a filter. We're not taking this lightly. I'm not, I am super excited about this research. I'm an author on the paper. I am going to be advocating for more research of this type. But I also want to point out that we should not be encouraging people to undergo these very extreme interventions until we know more. So, I am working with apheresis centers in New York City. I'm begging the NIH for money to explore this research more deeply. But I want to temper this good news with the idea that we want to keep everyone safe. We want to first do no harm, but watch this space. I think it's really promising, and all of the scientists who are working on this from all around the world are truly phenomenal. It's been an absolute pleasure working with them. So finally, I'll finish up by just, step 4 is just never stop talking, as you may have gathered from me not stopping talking. policy thoughts. These are the things that I'm working on with my team, and we're just being very loud and obnoxious about it. We're pushing for more multidisciplinary long COVID clinics. We're pushing for more mandates on insurance coverage for procedures and care related to use of long COVID ICD-10 codes, because right now you can get a long COVID diagnosis and they'll code you as a long COVID patient, but insurers still haven't agreed to actually cover many treatments associated with those ICD-10 codes. So we need state and federal level government lawmakers to say, you actually, if someone has an ICD-10 code, you need to cover interventions and tests and treatments. We need obviously more and easier to access disability benefits for individuals with long COVID. We're working with Social Security Administration on that, and we're being very loud and obnoxious. But we could always use more help. We're demanding more focus on resources and research to go toward members of historically and currently excluded groups in healthcare with long COVID. There's still the narrative that it is, primarily white, wealthy, primarily female people who get long COVID. That is absolutely not the case. That's just what we're seeing, in cohorts in America where these are what the clinics, are most likely to access. And finally, also just always pushing on not needing a PCR or antibody test to get a long COVID diagnosis or be accepted into a long COVID clinic. Mount Sinai used to have this condition, and we had conversations with the leadership of the Center for Post-COVID Care. That condition has been dropped. If anyone listening to this is trying to access the Center for Post-COVID Care and they get turned away on this condition, if you email us on prcovid@mountsinai.org, we will make sure that you get seen. Final slide I want to talk about is gaslighting. It's happening a lot. We all know this. I just wanted to throw out some helpful questions you can ask if you're being gaslit, because I think one of the most helpful things you can do for yourself in terms of advocacy when someone is gaslighting you is to ask questions, and ask very detailed questions. So, if, let's say, you wander into the emergency room with chest pain because you're extremely concerned about chest pain, and you start to experience gaslighting, really simple. They're telling you it's anxiety. They're telling you, it's nothing to worry about, just go home. Okay, so what is your differential diagnosis for my condition? What is, give me the list of things it could be. Let's forget about for a minute what you think it is, doctor. Just tell me what could it be? And then they'll say, okay, well, yeah, I mean, it could be a heart attack, or it could be, a blood clot in your lung, or it could be XYZ. So how have you ruled these out? What tests have you conducted while I'm here in the emergency room that have ruled these differential diagnoses out? Okay, so let's focus in on one of the things you said, a heart attack. What's the evidence for and against that differential diagnosis? So what is the evidence that I do or do not currently am experiencing a heart attack? Tell me what's going on. And then finally, and usually by this time, by the way, once you start asking these questions and once they start talking it through with you, then they're like, yeah, what would it hurt to do an ECG? What would it hurt to do some imaging? Because usually at that point, they're starting to get the vibe that, maybe if we don't do this, I could be in trouble. But if all else does fail, okay. So I just came to you with chest pain. You told me that it could be a heart attack. I asked for an ECG and you said no. Could you please document that you're refusing an ECG after telling me that it's possible it could be a heart attack? Because I'm documenting it. So I just want both of us to have a documentation of that. That usually kind of shuts down most of the gaslighting pretty quickly. So I just wanted to end with that because I know that there's a lot of this going on. And in my mind, this has been some of the most effective strategy for shutting down gaslighting pretty quickly. Please reach out, any questions. I want to acknowledge so many people that I work with who do all the work, when I just do all the talking, as well as, everyone who's part of Body Politic, everyone who's been part of our patient population of people with long COVID who are incredible and are always volunteering themselves for help. And I will stop the presentation now.
Dr. Putrino, thank you so much for that amazing presentation. We are so grateful to have you as an ally, as a champion for folks with long COVID, as someone who is, learning along with us and building off of, the history of these infection-triggered chronic illnesses and trying to build off of what we already know and what we hope to learn. Really, thank you so much for all of your work. Really quickly, I will introduce myself. My name is Angela Vázquez. I am the president of Body Politic, the grassroots organization at the forefront of the patient-led movement for long COVID justice. I recently assumed this role from our founder, Fiona Lowenstein, who founded Body Politic after they got infected, the Body Politic support group, after they got infected with COVID during the first wave of the pandemic in New York in March 2020. I also got COVID in March 2020 here in Los Angeles, and I am still struggling daily with symptoms and have collected a variety of diagnoses, including POTS, postural orthostatic tachycardia syndrome, MCAS, mast cell activation syndrome, and I also manage a full-time job and my long COVID advocacy through a very strict pacing regimen to manage my post-exertion symptom flares. I have not been diagnosed with ME/CFS or myalgic encephalomyelitis, chronic fatigue syndrome, but I have gone in and out of meeting the criteria for that diagnosis for the majority of the last 22 months. So again, thank you so much for being here, Dr. Putrino. A reminder to our audience that for this Q&A, we've got about 25 minutes. Dr. Putrino cannot provide individualized medical advice. This is not medical advice. This is not medical advice. This is not medical advice. And the questions below, the questions that we'll go through are sort of themed. So I'll try to stay on topic. And we've also tried to prioritize those questions from our support group that had the most interest. So with that, let's talk a little bit about research, since that was the topic of today's conversation. So the first question that I have for you is Mount Sinai investigating any antiviral treatments? And sort of, if yes or if not, sort of who else are you aware of that is looking at antivirals, considering, what you just shared about viral persistence?
Yeah, so a number of investigators at Mount Sinai are investigating different antiviral regimens and treatments for just flushing out persistent virus. So Saurabh Mahandru is one of the investigators that that we've been having conversations about, and you can see a lot of there's a lot of investigators at Mount Sinai looking into this, as well as NYU, Columbia. This is definitely a direction that people are going. I would point toward clinicaltrials.gov for antiviral therapy, clinical trials in your area. But there's a lot of this, and I mean, some of it is kind of crazy, and some of it has good, like ivermectin is an antiviral, and God knows we've seen a lot of back and forth about that. And I think this also speaks to the antiviral therapies are challenging for two reasons. First is, again, we still don't know what this persistent virus is doing to tissues. Is it just sitting around harmlessly, not causing reactions, or is it, is it out there causing trouble? And then the second is many of these antivirals don't take out the COVID virus. They don't take out SARS-CoV-2. So we're certainly watching the new Pfizer antiviral with a lot of interest. And I hope that someone at Mount Sinai will be involved in that clinical trial, because I think that that is a really promising avenue. It's, it's designed to knock out SARS-CoV-2 virus, and it's an antiviral. So I think it's worth a look.
Great, thank you. So I have a question here about sort of pancreatic damage, prediabetes, but I'm going to ask a broader question, which is sort of, what are you seeing in terms of the metabolic research, either his past research on, the metabolic stuff related to ME/CFS and how it's being applied to long COVID, or if there's anything that you know of that is looking at sort of the metabolic impacts of long COVID on patients?
Yeah, I mean, I think that honestly, I think the microclot work is a really good starting point. What Ricia and Doug are publishing on, and what Beate Jaeger's group out of Mulheim are publishing on, really can speak to some of this. It's the metabolic side of long COVID is very challenging because people's numbers are all over the map. But there is certainly, I know that the Body Politic group has spoken about blood lipids in many people getting out of balance. We certainly see that, we see that in clusters of the population. I find it interesting that HELP apheresis, which is the apheresis technique that is being used in Germany, was initially apheresis for lowering blood lipids. So there's an interesting sort of parallel there. I also think that similarly we're seeing diabetic-like symptoms. We're seeing spiking insulin levels, so on and so forth. These are things that we're seeing, but it's so challenging because they just like the autoantibody story and the cytokine story, they're happening in these clusters of individuals, and they're not categorically not happening in others. And that's what we're struggling with.
Got it. Thank you. Is there research going on that you know of around vaccine-induced long COVID symptoms or vaccine injuries?
Yeah, we are trying to, so Akiko and I have started collecting blood samples from individuals who are willing to share blood samples if they are experiencing vaccine injury. We don't have enough samples yet to tell a definitive story, but Akiko is working on this, as is Ricia, and she's been collecting some really interesting data out of South Africa, showing that individuals with vaccine injury also have a microclot profile, which I think is really interesting. It's still very low N right now, but it's we've seen all of this stuff around vaccination being able to modulate long COVID symptoms, either in a good direction or a bad direction. And now we're seeing individuals who are experiencing vaccine injury showing microclots. It's definitely interesting. It's a hard thing to study. It's kind of wild how many times I've been called an anti-vaxxer for suggesting that that some people are experiencing vaccine injuries. So it's a conversation that has to happen in a nuanced way, and patients themselves who are experiencing it don't want to come forward because in many cases they're embarrassed about their symptoms, which is terrible that we've placed people in that situation, but it's very real. And the emerging, I think Ricia, it's the most complete work I've seen so far, and Science magazine published a small opinion piece where they interviewed both Ricia and Akiko about it. And I think Ricia is the furthest along with this work, and it was fascinating to see microclots.
Great, thank you so much. And yes, agree that this has been a challenging topic even within our own support group, to provide that sort of safe space for folks who have both, like myself, I improved after my first series of Pfizer, but I definitely have friends in the support group who were worsened, who were seemingly harmed or at least set back significantly by the vaccine. So we need to be able to hold both as true. I'm going to skip to make sure that we try to get a variety of questions answered. I'm going to skip to treatment. And so I know you made the really important distinction between sort of treatment to cure versus sort of supportive treatment to manage your symptoms. And so knowing that, the question is asking which kind of treatment, with or without medication, is currently the most promising for symptom relief or as a cure for long COVID?
So I again, I'm going to sound a bit like a broken record, but I really admire Ricia Pretorius's work. She has really, she's published some phenomenal data around anticoagulation protocols in early long COVID. So unfortunately for many people who are part of long COVID support groups, the promising results with an anticoagulation protocol occur 3 to 6 months after 3 to 6 months of symptoms. But I think that we should be paying a lot of attention, especially with the current Omicron surge, to making sure that anyone experiencing persistent symptoms is, is exposed to this literature of a triple anticoagulation protocol, because her results, her data speak for themselves. So I think that is a promising therapy for early long COVID, and obviously I'm encouraged by the apheresis data. So we need to keep looking into that. I still, right in the now, in the short term, I really need to advocate for also just pacing and energy conservation. Like, I mean, it's so, it feels so, anti-intuition to do all the things you need to do for pacing and energy conservation, but it makes such a difference to so many people's lives. And while we're talking about sticking 16 gauge needles into people and doing all sorts of extreme things, while we're waiting for all of that to be de-risked and proven, simple pacing, remembering these things and following the rules can make a world of difference and prevent harm. I think that that's a really important piece as well, is that a lot of harm gets done with, trying to push even mild exercise if you're having post-exertional symptom exacerbations, and focusing on pacing is a very good maintenance strategy.
Definitely agree with that. On that topic, so how should patients handle backslides? So, we overexert, life happens, you have no surge capacity, you've crashed. How should we how should we manage crashes when we inevitably crash, and how can we maintain progress in the long run?
Yeah, I mean, honestly, I feel as though you guys are better to answer this than me, to be perfectly frank, in terms of I can tell you what seems to work best, but probably people with lived experience would have much better wisdom than me. But my observation from learning from people with long COVID that I've been working with is that during a crash, it's all about going into complete overdrive with pacing and energy conservation, absolutely not pushing yourself, absolutely ramping up hydration, sodium supplementation, all of these things that sort of give your cells what they need to recover from that immune and inflammation response that is occurring as a result of the exertion. You know, what we're seeing in people who exert themselves and experience PEM or post-exertional symptom exacerbation is that they get this crazy immune response that accompanies their extreme fatigue and other sort of crash symptoms. And so anything that can sort of soothe that, which typically means low stimulation, lots of rest, lots of hydration, seems to be important.
Got it. A little bit more of a concrete question. So what standardized follow-up measures are being used to track long-term progress for patients, whether in your clinic or that other clinics are tracking?
Yeah, it's a great question, and it's an important one, because how do you know if someone's doing better if you're not tracking things? We use a range of patient-reported outcomes as well as some objective outcomes. So we tend to have a different patient-reported outcome for each symptom cluster that we're tracking. So we, as I mentioned in the talk, we use the fatigue severity scale to track fatigue. We've got a questionnaire for post-exertional malaise. We use the EQ5D5L for disability, general disability, which gives us just an idea of someone's general functioning, and it's quite sensitive to change. So we like it because there are other questionnaires around disability that have quite a ceiling effect. So many people with long COVID are doing fine enough that they're actually scoring quite high on these standard disability measures. And so it's very hard to see if there's a slight change, which tells you if you're moving in the right direction or the wrong direction. We use the MRC breathlessness scale to track dyspnea in individuals. We use the, what did I say? Fatigue severity. It's getting late. Largely patient-reported outcomes is my answer. I'm trying to run through the ones in my head that we also do, but largely patient-reported outcomes on the one side. In terms of functional testing, we use the 10-minute walk test because it is, 10-meter walk test. There is another test called the 6-minute walk test, but most of our patients who come to see us are too severely affected to walk for 6 minutes. That would absolutely cause a crash, but a 10-meter walk is usually okay. And then we do a cognitive battery to measure, different cognitive domains. The battery that we use is called Brain Check, but there's nothing particularly special about it other than, it's computerized and it's very quick. So it's 10 to 12 minutes on a screen. It uses well-validated cognitive tests like the Stroop test, the Flanker test, Trails test. These are all things that are very well validated in the cognitive community. So that's how we measure cognitive domain assessment. And the one patient-reported outcome I was forgetting is the NeuroQual, which tells us neurological quality of life. It tells us how cognitive impairment is affecting quality of life.
Got it. Great. Thank you. Okay, we have about 6 minutes left, and I've got at least 3 questions that I really want to ask you. Yep. All right. So has your clinic seen folks who are discharged as, recovered who end up returning? And what do you think that is about?
Yes. unfortunately, yes, we've had about a dozen now individuals who we had rehabilitated to the point where they were actually telling us that I feel like I did before COVID, and then 6 or 7 months later they relapsed and came back, and we took them through autonomic rehabilitation, and they slowly ramped back up. But to me, this was a big indicator that obviously we're missing underlying pathology. I was really, the whole clinic was really happy the first time we discharged someone saying, I'm better, and so seeing them come back was pretty devastating for everyone involved. And it really drove home that we were looking at something systemic. We were looking at something that is persisting, under the surface, even when you're feeling good. It also led us to examine this idea of how much effort are you putting into feeling good? Because it's very easy to kid yourself that you're feeling great. And it's like, yeah, I'm feeling great so long as I don't eat that, and I'm doing whatever, activity regimen that I'm doing, and I'm drinking this, and I'm, rubbing the rabbit's foot and doing all of these rituals to feel okay. And as we dug deeper into our recovered cohort, that was very much the case. It's like, yeah, I'm good so long as I'm careful. Like, okay, unpack careful for me. And then it's like this laundry list of stuff. And that takes a lot.
Yeah, I'm nodding vigorously because I feel like I'm held together by spit, glue, and antihistamines, and that's that's about it. Yeah. Okay, last two, but they're sort of together. So are you seeing that clinicians in general are gaining more knowledge about ME/CFS and dysautonomia and MCAS? And what can health professionals do to sort of increase each other's knowledge and clinical skills in treating long COVID? And the reason I asked that question is because it was really important that we not put the burden of educating clinicians on patients alone. So what can other clinicians do to build their skills to treat long COVID?
Yeah, this is such an important question, because I totally agree with you. This idea that you're feeling so debilitated and you have to then educate someone about your own condition whilst paying through the nose more often than not, it can be pretty trying. I think that we need a lot more general advocacy. Like I mentioned, I never I never shut up about long COVID now, and so we need a lot more people just taking the time to educate. I've been so grateful for my team, Jenna, nights and weekends training up physical therapists on this is what you can do, because what we need is for these sorts of this knowledge to just be commonplace and part of the vernacular. And of course, as it gets into peer-reviewed journals and the majority of physicians are reading these journals, it starts to become more commonplace. So definitely there is education level that's raising, and words like pacing are becoming more common. People actually, clinicians nod when you talk about it, and they understand what post-exertional symptom exacerbation is, but it's happening in a very frustratingly slow manner. We just need more and more advocacy, more and more education. I'm always trying to get more clinicians to spread the word, because it's easy. I don't know why. It's probably just an ego thing, but it's easier for clinicians to listen to other clinicians somehow, and for it to stick. And so making sure that, yeah, the clinicians are taking up the charge and doing these things is really important. We need, the other thing I think we need is everyone seems to want to go back to normal right now. We need a big shout out to more conferences allowing virtual presentation, and allowing this information to be discussed, both for the ease of people with long COVID to present to a conference without having to physically be there, as well as, I've had to cancel 3 conferences now because I'm not going to go as a long COVID expert. I'm not going to go and speak in a room full of 1,000 people at a conference, but the conference organizers are saying, well, it will diminish the experience of the in-person listeners. We need to cut that out. That needs to stop, because that's another way that you silence the voices, and people don't get the education that they need, because as far as I know, none of the long COVID researchers that I speak with are going to conferences physically and speaking about things. So we need a bit more of that as well. Great.
Well, that is all we have time for today. Thank you so much again for sharing your expertise. I also want to personally thank you for your slide around combating gaslighting, because we also had several questions talking about strategies or asking about strategies. So thank you. That is a huge additional resource and tool in our tool belt for patients. So thank you. I also want to make sure that we thank our behind the scenes volunteers and Body Politic administrators, Lita, Rachel, and Marissa, for making today happen. Thank you so much to my colleague and friend, Lisa McCorkell from Patient-Led Research. And on behalf of Body Politic, the grassroots organization at the forefront of the patient-led movement for long COVID, thank you for joining us wherever you are. We are an entirely volunteer-run organization made up of largely COVID-19 patients. If you'd like to support our work, please contribute to our GoFundMe campaign linked in the video description. Thanks, everyone, and have a good evening.